It's been a long time since so many of us came in person. We're sort of excited about seeing each other. Isn't this great? Okay. Okay. Well, good morning, everyone. I'm going to call the meeting to order and welcome all of you, both online and in person. As I was saying to our individuals online, we have many people in the room. This is the first time for the, in 2 years that we've had so many people here. And so everybody's excited to see each other. So that's great. Okay, we have quorum. Let's go through introductions. We'll go around the table here. First, we'll introduce our members. So let's start with Joe.
I'm Joe Ruth, Colorado Springs. I'm Joe Ruth, Colorado Springs.
Maria Cordova with the Independent Center.
Yeah, just a reminder, the button you push is the face with the 3 bars coming out of it.
Debbie Levin-Stankiewicz from Colorado Springs. I'm a new member.
Chris Marie Larson, Park County.
Good morning, everyone. Jeff Barker.
I'm not on. Okay. Good morning, everyone. Jody Barker, Director of PPACG. Thank you.
And I forgot to introduce myself. I'm Bea Babbitt. I'm chair of the RAC. Let's introduce our members that are online. I see Marilyn.
Marilyn Massey, Colorado Springs.
Jen. Oh, go ahead.
Jen Nimmo, Colorado Community Health Alliance, the Medicaid program for our region.
Mary.
Mary Kapp from El Paso County Representative. Still confused by the, go ahead.
You're doing great. You're doing great. Eric?
Eric Bidwell, I'm a manager with DHS and I represent El Paso as well.
Bill?
Bill Bowles, Park County, with limited bandwidth due to the lack of high-speed internet up here.
I'm glad you bring that to our attention so we don't forget. Did I miss any members? Okay, hearing none. Let's welcome our guests. We have lots of guests in the room. Do you want to, and staff also? Do you want to start with staff?
Melody Dowell, Program Services and Contract Administrator.
Laura Cruz, Mobility Coordinator.
Melissa Martz, Program Development Administrator.
And our other guests?
Jason DeBueno, Silver Key.
Lori Wood, Silver Key. Linden, the Aging Center Director.
Lori Rossi, Aging Center. Project Director.
Cynthia Margiato, Field Program of Colorado.
I love your pearls. Okay, and let's see who our guests online are. Let's see.
Hi, I'm Connie Chavez. I work for the Independent Center doing emergency preparedness and 911 communications.
See, Cindy.
Hi, I'm Cindy Carvel from Silver Key, the Director of Community-Based Services.
Let's see, Jenny Danner.
I'm Jenny Danner, Director of Park County Senior Coalition.
I skipped over Icano.
Hi, good morning. I'm Adrienne Cano. I am the Director of Senior Health and Wellness with Silver Key.
Scott?
Scott Watson, Next Day Access, Colorado Springs. I'm the operations manager here.
Oh, good.
Dave?
Dave Summers and Vida.
Jolene?
Hi, I'm Jolene Hausman, Executive Director of Fountain Valley Senior Center.
Michelle? Kathy?
Kathy Lowry, Taylor Senior Coalition.
Is there anyone else? Well, welcome everybody. So happy to have you here, both in person and online. We're going to begin with our consent items. We have our agenda and our minutes. Are there any changes we need to make to the agenda? Hearing none. Our minutes, are there any additions or corrections? Hearing none, may I have a motion to approve the agenda and minutes?
I move we approve them.
Thank you, Bill. May I have a second?
Second.
Thank you, Chris. We have a motion to approve the agenda and minutes. All in favor? Guess we can raise our hands and see if we have sufficient there. So if you'd raise your hand both online and here. Thank you. Are there any opposed? Seeing none, the agenda and minutes are approved. Jody, do we have any public comments?
No comments have come.
No comments? Pardon? Oh, we can.
Jolene's trying to get your attention there.
Okay, Jolene?
Hi, I just wanted to take a brief moment because the RAC has been so supportive of Fountain Valley Senior Center, and it became public knowledge to my board yesterday and I'm about to announce it to the seniors at lunch today, but I have submitted my resignation at Fountain Valley Senior Center, and my last day here will be May 27th. So I just want to thank all of you so much for your support along the way. And Mark Bowers will be our interim director, and I hope you show him the same support you've showed me. Thank you so much.
I'm sorry to hear that, Jolene. You've been such a force of providing services to seniors in your area.
Thank you so much.
Appreciate all that effort and time you've put in.
And I believe I'll be at the next RAC meeting, but Mark will be on vacation, so I won't have the opportunity to introduce him, but then he'll jump on to learn RAC.
Okay. Other comments? Any comments from people in the room?
Comments from staff. We will miss you, Jolene.
Thank you.
Okay. Then we're going to move on to the report of our technical review subcommittee, and that's Chris.
Hello, everyone. I usually like to spitball a little bit, but this was such a great summary we put together and the staff put together that I'm just actually going to read it. That way I won't go off on a tangent, which I am known to do. The technical review subcommittee held their 2022-2023 funding review on April the 12th. To recommend where the allocated funds for this coming year. They had requests totaling, and everybody listened to this, $8,035,733. Last year's request was $7,494,510. Sorry, I can't read out of my left eye here. An estimated available funding was of $5,400,000 at the time of the meeting. PPACG did not have the state contract confirmed yet with funding. That's very important to remember. This was an estimated number. We do not know yet what the actual funding will be. We operated at this time with the flat rate from last year. That's another important thing to know. That's where we took our criteria from last year's flat rate, a flat rate from last year's request or last year's grants. We acknowledge that the contract could come in higher or lower, and we'll adjust at that time but needed. Please hear that. We do know that it could come in higher or lower, so there can be some changes. Evaluation began with looking at overall cuts based on the program service. I have to say, this is one of the hardest ones I've done in 4 years, because we really looked in detail at each program, what they were successful at, what their burn rate was not successful at. So we worked very hard. We got very hopeful. We put together, I think we were here for almost 6 hours with our last meeting. So we did put blood, sweat, and tears in it. So all of these decisions were thought through. Once the figure was determined, additional increases or decreases were given to services based on a 4-year plan, strategic review committee priorities. The current funding, usage rates, compliance with contractual processes, and provider funding allocation from the previous year, which is what I just said, only better. Recommendation, the final amount recommended by the TRS for contract providers, $3,324,771. PPACG and AAA services, or specifically AAA, $2,045,908 for a total of $5,370,679, which we left. And this is the lowest reserve we've had in a while, because we took some from reserve and applied it at the time, $29,321 in reserve to allocate later. So with that, with this attached TRS recommendation shows that the TRS, what we are proposing, that is essentially the proposal, and I need a motion to approve that proposal.
So your presentation is the motion.
And then I need a second. Debbie. Debbie seconds the motion.
And then discussion.
And then discussion. We're open for discussion. From board members. Are there questions or comments from our board members?
I'll make a comment. I agree with Chris. It was a very, very difficult meeting, because all of the services that were requested were services that we really need in our areas. And so it was especially hard to decide how we were going to have to cut, so that we could come up with a number that would meet what we were receiving.
Any other comments? Then we can move to a vote. All in favor, raise your hands. And I need to see the people online. Okay. Okay. And those who are opposed, raise your hand. Seeing none, the proposal is approved. This will move on then to PPACG board from here. And as was mentioned, this was a long, difficult discussion, because we could not give everybody what they requested. And of course, the services, we all appreciate the services that are being provided for seniors. So I appreciate all the hard work of the staff and the TRS committee in reaching these conclusions. Okay, well, thank you very much for that. Then we'll move on to our presentations. This is May, or just about May. And so we want Mental Health Awareness Month. And so we wanted to bring 3 service providers in that area to present today. And so we begin with Pearls of Colorado, Cynthia Margiata, and I used to read names at the graduation at the University of Nevada, Las Vegas. So there were lots of types of names that I got used to reading. And Cynthia, would you introduce your co-speaker?
And okay. I'm Cynthia Margiotta. I'm the director and one of the coaches. And this is Peg Nugent. She is also one of our coaches. The other team members weren't able to attend today because of other jobs they have, but we have grown and I'm very excited about that. So in an effort to do this in 10 minutes or less, we have a brief version of what we were going to do. If any of the board members are interested in our more 20-minute program, let me know. I'd be glad to email it to you. Okay, so a lot of people have I don't even know where to start. I get embarrassed. I'm sorry, but PEARL's Program of Colorado, and PEARL stands for Program Encouraging Active, Rewarding Lives for Seniors. And we are not coaches. We are not counselors. We're not therapists. We're here to help people, and we'll explain that a little later. Next slide, please. Maybe. Good. If you could run that, please.
I can't do the video.
Okay, thank you.
And I tried to find it, I couldn't find it.
Okay. Yeah. Well, it's a video explaining PEARLs, and it has an actual client from another agency. That way her privacy is kept. But what we have here is the PEARLs program. The idea is to take folks who are feeling a little down in the dumps, having depression issues. If you can go to the next slide, we might be able to explain it a little better. So here we have people confuse the three together. Therapy is for people who are feeling very depressed. Therapists like my husband, they go into their background. They look at what has caused that depression. What are they bringing forward in their lives? Case management is another program. Case management is where they actually do more of the actual collecting the information that is needed for the client and then presenting it as done. Okay, if they need housing, they find housing for them, they connect with the housing programs, and they get that done. What we do in PEARLs is we empower people. We give them the information. We get them to do the work themselves. That helps with depression, believe it or not. That helps relieve depression. That helps them to feel like they have power again. So we connect them with the agencies and they make the calls. They do the work. And I know it sounds like we're lazy, but it gives them more. And so we do a lot of referrals. We refer to these companies quite a bit because that's important to work together, to be a program where we all work together.
And we always pass out yellow books.
Yes.
There we go.
Well, those of you who know me, I'm a walking, talking yellow book, okay? You know, I believe in that yellow book, yes, because the clients, they can go through those. And I explain that. I'm not sitting in a corner with the yellow book. I'm bringing it to them. I'm explaining it to them. I'm showing the back cover for you who has that. I'm explaining these are the services that are offered in the Area Agency on Aging. These are the services that are supported by Area Agency. So, and yes, I'm in there a lot. But so does that help you understand the differences?
Because we also have to explain this to the clients that, no, we're not here to get you applied for something, or we're not here to, do this work for you. Part of why you're depressed is because you're stuck and you can't see a way out of your problems. We'll help you fight them eat that elephant one bite at a time and learn so that when we're not around anymore, you remember and learn how.
Right. It's an evidence-based program. So yes, we have to admit we didn't get, put it together ourselves. We do short-term work with folks who are depressed. We do short-term work with people that are caregivers who are dealing primarily with like the dementia or the overload. I don't know if you all know, but the Alzheimer's Association says that 6 out of 10 caregivers will die before the person they're taking care of. And you know why? Because they don't take care of themselves. And so I tell clients all the time, I fight you for you. I'm here to help you take care of you. And we do give them information about dementia and those things, because that's something that's been a long-time interest of ours. I've been a volunteer with them for 20-something years. So that's the work we like to do. And our other coach, she's a grief counselor. So she's a therapist. She gets a lot of those kinds of care. So next one, please. So, when depression in elders, there was a study done by John Hartford Foundation, if you've ever heard of him. And they say that a great number of people who go to their doctor, the doctor doesn't tell them the side effects of depression. Something like, what does it say? Yeah, 46%, there it is. 46% of people receiving treatments they say their provider has not shared with them some of the side effects of depression.
Or the symptoms.
And so what we do at Pearls is that we do keep in contact. We give them our phone number so they can reach us. We set appointments before we even leave their house. We offer continued support for about 6 months, sometimes longer if they need that. And then, we have a geriatric psychologist who's one of our volunteers. He volunteers 3 hours a month. He's very interested in the program. Most agencies have to pay for their psychologist. We're lucky he volunteers. And then, of course, there are very few people that understand those health issues that are associated with depression. And so what we do is we openly talk about their health. We make sure their health is primarily in our minds. We talk about exercise. We talk about social engagement. We talk about doing things that give them joy. What gives you joy? What have you done? What have you done this month that gives you joy?
And so there are actually 4 evidence-based proven strategies that help manage depression. Learning to solve problems, getting yourself to do something that brings joy, getting more exercise, and getting more socialization. And that's part of every session that we help people identify, what are you going to do between now and when I see you next time? And then as coaches, I get a text in between. I called my brother. Good job. And it's when you're depressed and feeling stuck, it's amazing what difference that can make.
So we also have a nurse practitioner to talk about, and she volunteers 2 hours a month, and she talks about their medications. If they're over medicated, sometimes that is, too much antidepressant or too much medication for anything. Sometimes people have one doctor that gives them a prescription for antidepressants or thyroid medication, and another doctor gives it to them and they've got too much. And so she looks at all their medications on a regular basis to keep track of that. And having a volunteer like that as well saves us some buku bucks. So we are hoping every year, we hope to keep those 2 primary volunteers. Next slide, please. So this gives you an idea. What we use to start off our business with folks is what's called the PHQ-9. These are the first 3 questions of the PHQ-9. And if you look at that, the adults, their numbers are much lower in the depression scale than people who are over 65. Okay, that's very important to be aware of. If you take a moment to peek at it, I'm sorry, it's a little far, but those are the first 4 questions that are asked. That says a lot about the numbers of people that are depressed. This month alone, we got 10 referrals. And that's a lot for 3 part-time people. Yes, ma'am. Yes.
Where do you get your referrals from?
All over the place. We get a lot from Area Agency on Aging. Yay. We get a lot from the Sheriff's Department. Adult Protective Services refers people. Family members refer people, and clients themselves, which is really, that was a surprise. Okay, because for people who are depressed, to make that phone call and say, I'm depressed, is very hard. So we do get a few. Those are the primary places we get referrals from, because we do go far out. We go to Yoder, we go to Payton and all of that. And there's a lot of people that are stuck. They don't get the one-on-one services. They can't, they're in a wheelchair. Their husband died last week. They can't get out of the house. We have to figure out how to help them help themselves so that they can. Next slide, please. So thanks to our grant, thank you, you guys, we are able to serve all of El Paso County. There is no area that we are refusing to go to or cannot go to. Some places we haven't been to yet, but if you know anybody out there, let us know. But we've been all over. Next slide, please.
Okay.
So this is a typical client on the screen, but Peg is going to talk to you a little bit about a specific referral.
Well, this specific referral is kind of interesting. The client that's described here really is one way in which the Referrals program can create real success stories, that people do what they're supposed to be doing. And we use that PHQ-9 to help see that over time, as they learn and practice the strategies, their score decreases, their depression lifts. I actually referred somebody who's near and dear to me, my husband. And this was during the pandemic. And at the time, you know, wasn't working with Pearls, but I just knew he was stuck. And Cynthia describes depression as often being, you know, getting glued to your chair. Well, my husband was glued with super glue. And on the one hand, his response was not what we had hoped for, certainly not what I had hoped for. I was expecting this perfect Wonder Man, but there's 2 sides to that. On the one hand, he did benefit greatly from having Cynthia come to the home when he was socially isolated, when he was stuck to the chair, to know that he didn't have to worry about making travel arrangements. He doesn't drive. I was working at the time, you know, so that was a great benefit, because when you're stuck to the couch, it's really hard. It's hard enough to make that call saying, can I have somebody come out? But to see that person, I actually have to get out of my house, you know, would lead to all sorts of cancellations. So, and he did learn some strategies. He did recognize the value, and with her encouragement, start walking our dog and taking her out, and doing more exercise. But you know, she would give him a calendar and make him, you know, track out your activities that you'd say you want to get done. And he stayed stuck. So this is where I say there can be a second side too. Because after a while, with his permission, Cynthia called me and she said, Peg, I'm concerned because Jim isn't responding as an evidence-based program would suggest he should. And that's input from her, which was so helpful, helped me to realize that part of his stuckness goes with the fact that he has mild cognitive impairment and he needed prompting. And I was working at Namaste Alzheimer's Center and leaving at home the cobbler's husband with no shoes. So that's, I know that's unusual. I had another case I'm just gonna share real quickly though. That was a tremendous success story because it was a woman who shouldn't have been in her home, but she didn't want to leave her home and she was 102. She ended up hospitalized. The son said, can you come and see her in the hospital? We used one of our tools, which is, you know, what is your problem? What are your goals? What are the advantages and disadvantages of different solutions? So the first thing is I used the PHQ-9, and in the hospital, she had none of the measurements for depression. She loved being in the hospital and getting the attention that she got. And I said, well, you know, when you were at home, your scores were a lot worse. That suggests to me that living someplace more like a hospital might make you happier. Let's take a look at the options because they're saying you can't be discharged home alone anymore. So option one is full-time care. Option two is going to something like a skilled nursing facility or assisted living. And she gave us the pluses and minuses for each of those. And then in the process, I left that with her son so that he could remind her that she had come to her own choice, that she didn't want to go home. She wanted to be placed someplace else. And she has been there a month and she is happy as can be. And even her kitties have gone in with her. Again, not what Joe Doe experienced, but pearls can work in lots of ways.
It's a wonderful, healthy program. And I appreciate that you guys are behind us and have encouraged us. We hope to get other folks involved in this state because we are the first ones in Colorado State. Our growing team, this is our team. There you go. So Dr. Dave Margiotta, he's a psychologist. Yes, he's my husband. That's why we got him.
Yeah, that's why he volunteers.
That's why he volunteers. We don't count him making dinner when I'm at work, okay? Well, don't do that. But I'm the director and one of the coaches. I could never give up the coaching. I love going to people's homes, you know. And then we have Peg Nugent. She has a doctorate and she's a chaplain as well. And then we have just hired Barbara Myers. She's a life coach and certified grief counselor. And we also have Vinny back there who's trying to tape us. Thank you, Vinny. And she pulled us out of lack of understanding about, you know, reporting, okay? I'm more of a hands-on person. So she pulled us out of that. So here's our wonderful team. Oh,
and Molly.
And Molly, I forgot her. Molly is a
nurse practitioner.
A nurse practitioner. She works at the state hospital in Pueblo. That's her full-time job. And my husband's job, he does exactly what we do, only he works in the nursing homes now.
Well, but he doesn't do exactly what you do. He does therapy.
All right. Well, he does more therapeutic work. He works at Deer Oaks, if you've heard of it. So I hope we stayed within our 10 minutes. Did we? Sort of?
Well, you might have gone a little longer, but we have the time today. So thank you.
Well, thank you so much. A question.
Questions, yes.
Yes.
When your nurse practitioner, after she does a review, med review with the client, if there is any type of cross-contamination with the meds, or you've got part of a med team that is not aware of the other medications, Do they follow that? Does she follow that up as a program to approach each of those practitioners to try to get them on the same med page?
We would love to do that, but what she actually does is she lets us know, and then we talk to the client and we tell them about the problem so that we can encourage them to talk to their own doctor. Again, we're not, in that position. We want them to be empowered. And so we also talk about, because you know how it is, a lot of people think the doctor has ESP and they don't share as much as they should with the doctor. This gives them more power. It's okay to talk to your doctor. It's fine to say, I'm on, a nurse practitioner. She suggests that we look at these medications and that this one might be too high for me.
Thank you.
Thank you. Any other questions?
Mary Cat has a question.
Mary Cat online. You have a question?
Where are you, Mary? There you are. Hi. Turn on your mic, Mary. Okay. Maybe if you put it in the chat.
It is in the chat. I'll repeat it here. If it becomes obvious that a person cannot accept the empowerment, do you help them link up with case management?
Oh, absolutely. 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 We have several connections, including Silver Key sitting here, where we can refer them to appropriate people. We, in that case, we do call the case management program and tell them that we're going to make a referral. Do they have openings, that kind of thing, where they can take people. And then we do talk to the client and encourage them as much as possible to make that call. If they can't, then they have this person who might call them.
And we also freely make referrals if they need an actual therapist. One of my clients that I knew from an Alzheimer's support group, the first time I did the PHQ-9 with her, it came out at 21, which is just about the max. And so I made sure there wasn't suicidal ideation involved. And then we offered some referrals to therapists. Unfortunately, finding therapists with openings these days is kind of hard. And it's really rough if you refer someone and then they call someone and they keep being told, no, I don't have a slot. So if you know any good therapists with slots, let us know.
And I, just before you ask this question, I do not refer to my husband. Sorry, he's a great guy. But
can I ask a follow-up question?
Sure, go ahead, Mary.
Is there, I'm assuming there must be, but if these folks have a caregiver, is that caregiver part of this whole process?
No, actually, well, do you mean like a caregiver from a home care or from a family?
From the family.
Oh, from family. We do have contact with family. Just yesterday, I was talking to a gentleman who was referring his mom. And so he was giving me the lowdown a little bit about what her needs were. And I'm very honest with the clients. And when I talked to her, I said that her son had referred her. And we only talk to family with permission. And so family has to say, yes, I'm sorry. The client has to say, yes, then I can talk to the son, daughter, whomever. As far as caregivers from agencies, no, we don't feel it's their spot.
Okay.
Thank you.
Are there other questions? Well,
Bill
thank you.
Bolter.
Bill, go ahead, Bill.
My usual question is, what are the plans of going on west up into the mountains?
Yeah, for sure.
Unfortunately, our grant covers El Paso County. So I would love to be able to expand out there. I have several people that I know. Kathy, is that you, Kathy, out there? So.
Yeah, we'd like you up in Teller too.
Yeah, I'm sorry.
Bill, and I believe, Cynthia, you are trained to train and expand programs, aren't
Yes.
you?
I took the classes so that I can teach other agencies this past year in the hopes of bringing them to other companies. Other places, other areas. get more staff. Yes, it would be a dream come true.
Okay, thanks so much. I think we need to move on to our other speakers. We really appreciate all the information you shared, and you'll be in the room afterwards. Okay, our next speakers are from Silver Key, Jason DePuino, President and CEO, and Lori Wood, COO.
And I think I've got a presentation. Just so you know, normally I would not put a picture of myself in the presentation. However, I have an upper respiratory illness and I'm high on like 5 medications right now. So I want you to know that I'm smiling underneath this mask. I'm thrilled about being a part of this, but I'm also a little bit aloof in what's going on. So my picture there is just to demonstrate how happy I am to be part of this presentation. If you want to go to the next slide. Also, I want to introduce Lori. Lori Wood is our new Chief Operations Officer. We've had a significant amount of growth in the organ. There's the smile. There you go. Keep going. Okay. And then Lori Wood is our new Chief Operations Officer at Silver Key. We've had a significant amount of growth during the time of COVID. And what that's meant is, and translated to, is that we've had to figure out how do we create enough operational infrastructure support to manage the demands that we have across the community with all the different services that Silver Key offers. And I'm so grateful that Lori has joined. I think both Lori and I were involved with the organization since the 80s in different capacities. And for those of you who don't know, Lori lives in Manitou and has been part of the community for a long period of time. So welcome aboard, Lori. And with that, I am pleased to be able to be included among the presenters of UC Aging Center, and then also Pearls for Silver Key. If we go to the next slide, Pearls, Silver Key, and UC Aging Center are around the whole range of services for individuals with behavioral health needs. But before I move forward, I want to share with you that, just to give you a little bit of the day in life of, that right now, globally within our funding that we have, not only with AAA, but with certainly sponsorship, with donations and other resources that we've got in the organization. On a daily basis, we offer 118 rides a day, 706 meals on average, calls of reassurance, 193 calls happen daily. We serve 56 clients through our pantry, and we have over 46 visits happening through a companionship program that we have. And again, all of that happens within the day. And the reason why this is a very salient snapshot of what Silver Key is and does is on the left, it talks about the level of support that we get from volunteers to be able to actually make this magic happen. We're one of the few organizations that has the core of 450 plus volunteers to be able to make all of this happen. And the good news around that is that we serve a lot of people in a lot of great ways, but you have to have a structure to be able to support that growth. And so that's what this all means. And I just so much value our resource within our volunteers. If we go to the next slide. Okay, now I'll slow it down. Okay. Now the presentation about behavioral health. One of the things that's happened is that you'll see here is that we, through the funding up until March 31st, we have 3,700 services that have happened with counseling, screenings, and case management. Included with that are very significant, very ill individuals to the point of suicidality, homicidality, and other issues of review that are significant. Also, we have a number of individuals, as was shared with Pearls, that we have to manage to be able to link services through case management. And that is very much part of our whole person care in our behavioral health area. The screenings that we talk about are to be able to make sure that we understand where people are presenting in terms of their level of hope and what that means for the care that they need. I've shared this before with the RAC, that there's a tool, an instrument that's valid and statistically reliable that talks about what hope means in people. And what this particular instrument does is it gauges if somebody has a lower degree of hope, then there's a higher utilization of emergency room, inpatient level of care, skilled care. And so the idea is that we're using this as an organization to be able to really understand our outcomes from What does it mean about the impacts that we have related to counseling, screening, case management, and quite frankly, when we bridge in all of our other services related to transportation and our meal program, our companionship, what we're doing is we're outfitting that if we can increase the hope of the individuals we serve, in contrast to that research, we're able to demonstrate that by increasing hope, we reduce the level of inpatient level of care, the need for skilled nursing care or assisted living care. It's a really intuitive, when you hear it, it's intuitive, but at the time it may not be. So it seems a little squishy and that kind of, but the reality is true. Hope is one of the most powerful impacts in a person's life. And that's really why Silver Key exists, is to broaden that level of hope. And we do that not only with the individual, but through the context of the community and whoever is part of that individual's life, whether it's family, friends, etc. So with that, that's what the funding that we get right now from the AAA has been able to help us do. In terms of our next slide here, I'm really excited about one of the things that has happened recently is that we have been designated by the state of Colorado as a health service core location. And what that means is that we have now the availability to be able to hire some therapists and other folks that are licensed, and we will be able to help to eliminate their student loan. And so what that means is it's a way for us to be able to recruit a workforce where we're struggled to be able to bring therapists into this organization. The fact that we achieved this is a huge, huge step because the only two other agencies in town that had this designation was the Community Mental Health Center and the Community Health Center in Peak Vista and Diversus Health. So these are very large organizations that receive that designation. And the fact that we have little scrappy Silver Key able to apply, justify the level of need and the level of populations, complexity with the senior population, I'm thrilled that we got this approved. And I believe that's going to be able to weigh to, as was shared, we don't have enough capacity in therapists. So this is going to hopefully be able to bring more capacity through the community so that we will be able to hire at the rates that we're able to with that loan forgiveness option. The second point I want to share with you is the oneness concept. What we're working for at Silver Key is we have 50 years of history in the community, and with that, several different programs have evolved over the last 5 decades, but sometimes those programs have grown in isolation of each other. I've shared this with our staff and with our board that in some ways, I believe that the organization at times functions like Hawaii Islands, in that each island has a unique kind of experience about it. You may have transportation that's specifically concrete around transportation, but it may not necessarily integrate with the big island of, let's say, nutrition or behavioral health. And so what we're doing is we're lifting up higher over the islands and be able to say, let's have an infrastructure so that when we have an individual that comes into care in either our behavioral health area or our transportation or our nutrition area, that we're really understanding more globally what the nature of their needs are. So that way we can draw from the different islands and wrap around a full service array that makes sense for that individual. Because similar to what Pearls was saying, if we're proactive and preventative, I truly believe we can build resilience in individuals and actually become more effective and efficient so that we can serve more people. But when we have a fractured system in the way that things have evolved, that makes it a little bit more challenged. So we may have an individual that's served by our transportation at this moment in time, but we may not fully know that this individual is also served by our connection cafes. And we may not know that this individual is served by behavioral health. And that may not make any sense to you, like, wow, how does that happen? The reason it happens, and it's not dissimilar from a lot of nonprofits, Silver Key in great ways put services in front of building the infrastructure to support it over the decades. And what that means is that we have disparate IT systems, we have disparate software. And so what we're doing is we're collecting all of that and we're moving to a platform that will be able to have a single client ID and naming convention. So that way, when we know an individual's in care with us, we know the entirety of what they're in care receiving and also what they need. That oneness of Silver Key is a piece that we're moving forward with in that whole person care. The other challenge that we run into is group supports and expanding our group care. One of the major issues that we have is the funding that we have to be able to provide all the services is very challenged with the amount of people we serve. So we have to rethink our service mix and our models. So what we've done is we've started to add group solutions in our behavioral health area. For example, we can make direct referrals to be able to help individuals with utilities. In the past, we did this on an individual basis. The problem is that we don't have the capacity of staff to be able to manage on an individual basis. So there's always, you know, that when you think about the circus and that balloon and we squeeze over here, balloons over here. So what happens is we get the squeeze on the resources. We have to think differently about how we solve. So what we did is we've added group solution like for utility assistance. So we schedule 10 people at one time to be able to go through this process. And we've done amazing with being able to bring people together and actually build some of that connection. As was also said by Pearls, it isn't about us fostering a system of dependence. It continues to foster a model of independence. And independence also means connection with cohort and people that are in the same situation oftentimes, so you can learn from each other. How did you get through that utility piece? And even just to be able to understand another story gives power to be able to share your story. And we're finding that in some of our group models that we're moving through. So again, our three major accomplishments that I'm very excited about, the fact that we're going to be able to hire more staff in the therapeutic area, that oneness, bringing our islands together. Oh, by the way, so from the Hawaiian island, my thought is that when you go to Hawaiian Airlines, you have that same experience regardless of which island you go to. But once you get to that island, then you get what you need in that island. That's what I'm talking about. Silver Key is going to be the new Hawaii. And then also group supports that we need to, look at you, I love it. And then also group supports. We need to continue to expand that capacity through different ways of moving forward in care. Melissa, if you move forward next. Oh, yes, ma'am.
Button.
So some of what you said with being able to know that there's transportation, there's nutrition. So those folks that are case managed, isn't that something that a case manager would look at and know all the different services that they're doing? So is this above and beyond what your case managers are doing, the people that aren't case managers?
It's such a great question. So what happens right now is the answer is yes, that's what our case managers do. But one of the things that happens is if you call into Silver Key at our Silver Line and Jane Doe, we put this in, we may not be able to initially identify where you've already been in service with us before. So what that means is that we become inefficient because our case managers have to learn some of that piece because we've had so many years of history of serving people. So this will step it back so that we have one database so we can understand where that person is in care within Silver Key, because we serve over 9,500 people a year. So it's very difficult when we have those broken systems. Does that answer? Mm-hmm. So the challenges, to the question that you just asked, actually, integrating services under a common treatment plan has been a growing initiative that we have in our organization. What I mean by that, I want us to be able to understand who this person is, what those needs are, and create a golden thread so that we make sure that everything dovetails together under one common path for care, again, to build that overall resilience, and that will translate to increasing hope. And when we increase hope, that means we're reducing the cost to inpatient, emergency room, and we become more effective and keep people in the right level of care for a longer period of time. Just as Pearls was describing in the way that works, that's what we're moving towards. And it's been challenged because many of our different systems have grown differently along the way. And so we're moving through those processes. Continuing to deliver both homebound and in-clinic therapeutic services. The model that we have right now is primarily home-based. We certainly have in-clinic care where people come into our offices. The problem is that the home-based models are very, very expensive. And yet there's many homebound individuals that's the best case that we're going to be able to do. So we don't want to take away from that, but we've got to figure out for those who have the capacity to be able to come to the clinic, especially as we've moving past COVID and those issues, that we want to be able to make sure there's enough access. And so that's one of the things that we're looking to do, is making sure we have the capacity on both fronts for in-home as well as in-clinic care. Thanks, Melissa. The picture on the side there, I'm sorry, just real quickly. The picture on the side there, one of the things that's happened is that's my office. Just kidding, it is not my office, although it sometimes feels that way. But I will, although it sounds like some people can relate, I think. Look at Melissa, she's like, oh, maybe. No, let me share with you that, I mean, I'm kind of making a joke here, but one of the things that's really tragedy in our community is that there are a number of individuals who have such a level of obsessive compulsive disorder related to that diagnosis, and hoarding tends to be one of the behaviors that were coming forward in what they're choosing to do. And so what that means is that there's so much challenge for people to navigate their own home because of the safety issues, and because we have some individuals that we've tried to help by replacing refrigerators, but we can't even get the refrigerators out because the level of just stuff that's in the home. And we've worked, I know Eric is on the line, I saw him earlier, but we've worked with APS to be able to manage some of these situations. But what we're doing is, because we're moving forward in that behavioral health area, we're stepping back and building our core competencies around what does it mean to be able to address the issues of OCD related to hoarding behavior, and what role and responsibility do we have as a behavioral health provider. And I'll tell you a little bit more as we move through that, but that's why that picture is there. If you keep moving forward, please. Okay, so the number of people on our wait list is now at 26, and it continues to grow every day. The fact is that we've got a lot of needs. The resources that we have are very lean. And so that's that. We'll keep moving. So this slide here, I wanted to share with you is that this is actually overall where the organization is. We serve more than 11,000 unique clients every year. Our health and wellness is at 4,400 clients, food pantry, 27,000 boxes provided, over 1 million pounds of food, 28,000 rides a year, 175 meals provided. And then our volunteers provide over 35,000 hours of care. And all of this happens with the support, and I'm the TRS and this committee making the recommendation for our funding is very much appreciated. I will share with you, however, that what you may, and I know it's a puzzle as you were talking about to be able to make those decisions, and I appreciate it, I really do. I will let you know that one of the perceptions I believe out there is that because many of our nonprofits that are part of the provider community have the flexibility to be able to raise donations to make up the difference between what we deliver versus what we receive through contracts. The reality is that resources are becoming very lean across the community. Our donation base is actually, it hasn't really grown at this point. We have grown in some corporate sponsor, which is great. But the reality is the gap between what we have in contracts to serve and the amount of people we serve is stark. It's huge. And so one of the things that we are trying to problem solve is that how do we manage, particularly after COVID, when we knew, and I've shared this with Jody, I know that we're responding right now in COVID, but I don't know what that means afterwards, because there's going to be so many more people that we're serving, which is the case, and we didn't know what that path forward is. Silver Key is committed to serve the people that we have today. I am struggled with trying to figure out how we're going to be able to continue to grow with the contracts we have. So with that, one of the other opportunities that's out there is we are moving forward with billing Medicaid for some of our services. And that has been a real challenge for myriad of reasons. But the main challenge being is that when an individual is becomes 65, if you had been 64 years old and you were resilient because you had access to advocacy and case management, that's a covered benefit under Medicaid. You had a covered benefit under Medicaid for advocacy and case management. Happy birthday at age 65, it goes away because the perception is that Medicare's behavioral health benefit covers case management and behavioral health. The reality is credentials that can deliver behavioral health care are so limited, and case management is not fully covered only in the primary care area of that. So what happens is this individual system falls apart because there's no resource to cover advocacy, peer support, and substance misuse. And by the way, substance misuse in older adults exists. Alcoholism exists. Medication mismanagement, pharmaceutical exists. We have got to make sure that our system is responsive to those that are over 65. It's a tragedy because here's the tragedy. The way you can reactivate that level of support, ironically, qualify for skilled nursing care, qualify for inpatient. Then you can now activate case management and advocacy. It's the most, somebody besides me is on medication in that decision. So we're working to be able to, we're trying to, what we're doing is working with Innovations in Aging, and we're working with the fire department, and we're working with NAMI of Colorado Springs, and we're pulling together a research paper to demonstrate that with our proactive, preventative, resilient making model, that we will actually be able to save the state money in the Medicaid model by investing now versus waiting till they get to that level of care. So I'm going to just let you know that this white paper we'll be putting together at the end of this fiscal year, and we'll be generating that, and we'll be sharing that with the RAC as well. Yeah, I probably have taken more time. I'm sorry. I can answer any questions if you have.
A couple of questions,
Yeah.
if you don't mind. My name's Chris.
Yeah.
Park County.
Good to see you again, Chris.
My button's on. As far as your the Colorado Health Services Corporation, how are you funded? Who funds you? Is it a state-based funding? Who funds to pay off these loans?
This is out of the state and fed. So what it is, it's an approval process. So once you get designated as an agency, then the federal government or the state eliminate that student debt for that provider.
And it doesn't go through a particular agency?
No, it doesn't go through. It's a state and federal system directly, and the candidate has to apply for that and then be selected within an agency that's been approved, like us, and then they would go and then they work directly with the state or the fed to get that erased.
So the candidate themselves, are they approved prior to being hired by your organization?
Well, our organization is approved, and then they would apply at the same time. Yeah, good questions. And just so you know, it's $60,000 for a 3-year commitment is what that is on the licensure side for a therapist, and then $100,000 for a medical provider. I forgot to say one other thing is that we are moving forward with a psychiatric advanced care specialist to be a nurse prescriber in our organization. I'm really excited about that, and we're projecting we'll have that by the end of the year. Yeah.
Just 2 things. I want to say that allowing student loan forgiveness is another way to get more professionals into working for agencies that are dealing with seniors, so that as they become professionals in the field, they recognize that, and then they can bring that information to their social worker organizations, psychology organizations, and then they can advocate for more services. I just want to say, I worked in an area agency for 9 years, not in this state, but one of the things that was always problematic was, our agencies would complain about having to gather all the information, the numbers that you presented to us. And those numbers are so important to make the feds and the state people recognize how much services are needed, so that they're less likely to cut funding for those services.
Yeah, one of the challenges that we have is that we've got 6 different, arguably 7 different systems that we work with, whether our transportation uses something called Route Match, our meal program uses Serve Tracker, and each one of them have that data that you're talking about, but it doesn't come together. So what we're doing is we're creating what's called a data lake. And this data lake will have all of that funnel through, so that we will be able to tell that story, because I think you're right. I think we've got a compelling story, not only just Silver Key, but the providers in behavioral health, but globally. And the problem is it's one of our biggest challenges is being able to get those dollars flowing into senior services. And the workforce piece, you're right. I think that more people, if they had a chance to be able to be engaged, I'm smiling again in that picture. If they were engaged, they would love the field. And I think that this is an opportunity to build something.
Medicare and Medicaid more aware of how they can help lower some of the other medical costs by providing those services through Medicare and Medicaid.
Yeah. So there's a concept called social determinants of health. Social determinants of health. If you've heard about this, in social determinants of health, we live squarely in that. There's recognition now at Medicaid and Medicare levels that transportation access, that social isolation, that nutrition, that case management, and that also we have access to durable medical equipment and housing. These top 6 items are what our community sits squarely in. And what I'm so angry about is that for too long, the faith community and the nonprofits who have been working so tirelessly to be able to make this happen, we're finally finding our path that we're going to be recognized in the social determinants of health model. But the problem is it's going to take a long time for the insurers to understand, if we invested in the faith community that does social outreach, if we invested in the nonprofits that do this good work proactively and preventatively, it's actually good for them. But we've tried to work with our insurances to figure out a different way to get some contracts to support what the AAA can't. And it's like smoke. And so I'm hopeful, but I'm also realistic that we're trying to be solution focused. That was probably medications talking, so now I'll stop. Okay, good, all right.
Of where that problem of how do we serve our communities. That's where the problem is.
Yes.
Right there. Those 2 pieces do not talk to each other.
That's exactly right.
And because it's the payment, but it's also a mindset. The mindset brings action. And without the mindset, you can't even start to solve the problem. Thank you.
We have a comment by Eric.
I just wanted to real quick, I appreciate the presentation, Jason, and I totally agree too that, you know, when we're talking about the mixture of behavioral and, you know, mental health and older folks, you know, as adult protection service, we can go out to a home, and oftentimes the perception from the general public can be,
Eric froze.
It sounded good though.
I think what he was going to say is that the perception of the community is that APS is not people friendly. And I will tell you, my experience with them has been very positive. They are all about helping the seniors. They want, you know, they work with 18+-year-olds. They want to make that difference in their lives. They want to get them the help they need. They go into all kinds of areas to make sure that the folks get their needs met. So in a positive way, APS is wonderful. I love them. I would have applied with them 10 years ago, but I thought they were like everybody else. They're, you know, that they were mean. They're great. They're great. So
Eric, do you want to try again?
Sorry.
Thank you, Cynthia.
I'm so sorry. My internet has been giving me all kinds of fits the last couple of days. I just wanted to say that I appreciate the partnership on those cases. And it is really a combination. If that mental health component or case management component long-term doesn't coincide with the problem up front, it cannot be successful, because just months later, it can go right back to the way that it was, even though maybe thousands of dollars were invested to clear out or clean up or help create a safe situation in this individual's home in that moment.
Yeah, Eric, just so you know, Adrienne Cano's on the line. She's our Director of Health and Wellness. But one of the things that we're exploring is to evaluate what we know the answer. We know definitionally what this means. In the idea of gravely disabled, which of course APS doesn't have necessarily, that's not in the scope and role of APS, but for a behavioral health provider, it could be. And so what we're working to do is figure out if we have an individual who's in that safe, secure, unsafe situation, and we were to move forward with the idea of using our behavioral health team to move with gravely disabled, that could activate a larger system of support for longer sustainability. The problem is that it's fractured at best in that path. So I want to pull together a community of leaders to be able to say, what would it take for us to do this? And I'm going to lean heavily on Adrienne as we do that, because I think that we're missing the bridge between what our different core competencies are to make that happen. So thank you, Eric, for saying that. And we will be leading some of those conversations.
Thank you.
Thank you.
Thank you, Jason. I think we're going to have to move on.
I know. Okay.
Thanks so much. And now we have our UCCS speakers. We have Madeline Lim, Executive Director, and Lori Rossi, Program Director.
Thanks, B.
Debbie and Chris, do you want to turn off your microphones?
It's good to see everybody. Haven't seen many area agency on aging folks in a few years since I've volunteered, but it's good to be here again. So we appreciate the opportunity to present our work and our services, and we know certainly you all have a choice in what organizations and programs you choose to fund. And we do hope you'll continue to view the UCCS Aging Center, as one resident put it, a hidden gem in the community, providing highly specialized services and resiliency to our community's older adults and caregivers. While we enormously appreciate the recommended funding allocations you outlined, we do encourage you to please keep in mind that the Aging Center, unlike most organizations, does not have the ability to apply for carryover funding. So our programs will be dramatically impacted by the recommended reduced funding compared to our costs presented to run the services. So it just happens to be something that we have being embedded in a university setting, and we just don't have that ability to utilize carryover funds. So it's a bit of a handicap for us. So with that, before I start slides, I'd like to have Dr. Magdalene Lim provide some brief definitions and some differences of some terms to help put them in perspective, similar to our colleagues at Pearls did. These terms, she's going to talk about behavioral health, mental health, and cognitive health. And I hope it'll help with the flow of our discussion today.
Thank you, Laurie, and hello, everyone. So nice to be back here after 2-3 years. I'm a clinical psychologist, and I am the clinic director, so responsible for training, community services, supporting the university's research, And I feel like everybody already knows the concept, but I just want to point out the obvious. Yes. Oh, sure. I thought okay, all right. I just want to point out something that is obvious that we all already know, but probably our clients' families don't quite know. Our colleagues and peers sometimes would use the word behavioral health and mental health interchangeably, and there's really nothing wrong with that. But the difference now is that when we are dealing with older adults, part of what the training we get from institutions is to look at the ethics of it. Hardly we are able to talk about ethics or the qualifications and training of providers, because the first thing we want to know is we cannot work beyond our limitations. So when we talk about behavioral health, mental health, what does that mean? Initially, behavioral health was very much in the integrated setting. And so it is so important to know that that is the first place, patients get to know they have depression or anxiety and can get some support. So in the setting that I have worked, that's how it all started. And thinking that makes wonderful sense because many of these patients otherwise wouldn't have service. So typically it's a little bit short term. They do 6 to 8 sessions, and then they get shifted out to other areas of mental health facilities. So the relevance here is what the Aging Center does is really a specialty area. All right. One of the very important reasons is because older adults, particularly those with cognitive problems, can be so vulnerable. So taking care of their safety, and then if they have dementia, to let them have a very dignified experience, being served, being provided care by people who knows the full spectrum of care needed. So in that behavioral health, as it says, changes in behavior, whether it's diet, whether it's substance use, and it's a great big area to take care of. When I talk about mental health, then I'm talking about a lot of more complexities. And I like the way you're arranging the program, right? Like pearls and then silver key. And then for us, it feels like there's so many different levels and steps of complexities, and that requires a little bit more training, a little bit more diagnosis. And very simply, if you talk about schizophrenia, if you talk about bipolar disorder, if you talk about hoarding, all those require a lot of specialty training. So in the whole range of older adult population that we are serving, for us, we have to be so careful to know who needs what. And in doing so, I hope we become a little bit of the umbrella to help spread the word in the community. So we are a training center for students who cannot graduate and support the geriatric population. And the workforce in the pipeline is just so few. But for those who have successfully done so, they are all over the States. So some have returned, and I'm very happy to say that, there are some of them in private practice. So finally, I just want to talk about cognition. Cognitive assessments, what does that mean? From a spectrum of a screen, of a 10, 15 minutes screen, just to tell us whether they need more testing is important. And with area agency support of funding, we have memory clinic, which is in the middle space before they do a full-fledged neuropsychological evaluation. And that has been very successful. It's like a first foot in the door. All right, so we have some flyers there, and we feel like not only is it important that they do screens, people who come tell us they have a year or two that they feel so good about not having to be worried. Just like socializing into memory problems, right? If we think we're old, we cannot remember, and we try not to do anything, then we suddenly get to a point where we cannot remember things. So people who say, I forgot where I put my glasses, where I put my keys, love the memory clinic. At the same time, they have families who bring them in, or couples who come together because one has problem, one doesn't have, and they point to each other to say, hey, I think you are the one with the problem, not me, right? So that has always been helpful for a conversation. And caregivers has to be our next big focus. Aging center is not big enough to be able to serve everyone, but I think the education piece is so important. As we join forces together as a community to spread the word, to have conversations, it's through all those conversations that we know what's really going for them. And so I also have people who talk about neuropsychology to be equal to neurologists. They're totally different. Okay. So I've met some nurses, I have met some of my allied health colleagues. They still do not know the difference between a neurology and a neuropsychology. So in a nutshell, I want to quickly say, in neuropsychology, the hallmark from which all services can be provided is critical. And I have seen the success when caregivers say, oh, no wonder she is behaving that way. Now I feel better. Now I am less guilty. Now I know why I have to give way. Now I know how to manage my loved ones because we give recommendations. It is not medical, but we integrate the data from medical field, from social, their social network, and most importantly, the people next to them, right? The family, who knows better than the families? We cannot claim we know better. So only with that kind of conversation and a feedback, which research has shown very clearly. All right, when we test someone and then we do the feedback, everybody is on the same page now. Why somebody behaves that way, what kind of services are needed, nutrition, exercises, and then support for caregivers. Okay, so I have a lot to share with you, but I hope I'm not confusing you, but just want to get you thinking about what is it that together we can do. And I appreciate all the support that you all have been giving us today. Although I would say one of the services that we have, like memory clinic, the algorithm that is used to think about whether we have met the target we have committed is a little bit different during this pandemic. Because although we have a lot of interest for people doing memory clinic, they did not show because many fall sick. So many had COVID. We had to cancel so many of these. We have the students, our neuropsychologists always ready. And every day my job is at the door to say, what happened? Tell me the reason why they did not show. And it has never been because they do not want. Something is amiss. Caregivers fall sick too. Yeah, if there's a chance for more state funding, that would be so appreciated. Yes, hi.
When you first came and gave your presentation to do this integrated memory clinic or aging center, how would you say, even with COVID's impact, the idea was wonderful. We were all pretty blown away when you presented that, taking the cognitive behavioral and then the mental component. How would you say you have succeeded in that? Have you developed a true blueprint for other organizations to utilize with that short screening that really points people in a direction?
Yeah, I think two ways to answer that question. One is yes, in terms of the screen. So with the support of all of you, we were funded a little bit on education, from which we understand that providers are not really pushing for the annual wellness visit that Laurie has been promoting. So we have requests for quite a few places. Peak Vista Group particularly is huge. And so we've done free training with them. Because even if it's a simple screen, like the MOCA, for example, you can just go Google it. It almost is like everybody can do it, But it's different. The training is so important. For example, we have done, when I was in upstate New York, in the Rochester Medical Center, I do training for medical interns. And they tell me a score of 15 over 30 and a 17 over 30 is an improvement, and it's not true. There's only a cutoff of a score of 26. And then for that kind of screen, people look at individual domains. For example, they test memory, they test language, they test organization, executive function. And the screen is not meant to be torn apart. So people who are not trained will look at it and say, oh, memory is no good. This is good. That's not the way to be done. A screen is a screen. So a cutoff or not. And then you move to the next level, which is memory cleaning. And I think the other question is about, whether we were able to develop anything and train. There hasn't been anything in the field that has this what we call the mid-level cognition, right? Because in thinking about older adults, we are hoping that not everyone needs to go through the many hours of neuropsych full-fledged, evaluation. So we came up with this memory clinic, and it's unique to us because we have developed this over time. And we cannot actually have others do that because it requires a training. So for example, we have students who do administration of tests. So testing is not difficult. But do you have someone to evaluate all other clinical data? Because it's very critical what we say. We can't, so one other thing is like, if you're educated and your score, you can even got a full score. it doesn't mean there's nothing wrong. See? But that requires a lot of conversations, a lot of training. And you pointed out something very important here. We need to think about how to export that kind of expertise. Yeah, I hope someday, the campus has got money for somebody to test that out and send it out for people to do more of that cognition. So thank you for asking.
Sure. So another input to that, one of the things that in absorbing data was simply that there is a gap that happens. There are people that as their cognition starts to deteriorate, and let's say they get a questionnaire. Let's say they get a questionnaire yearly, 6 months, quarterly. Those that still have an intellectual capacity have the ability, if that questionnaire is not administered and changed in its delivery, they memorize it, or they're aware enough of what they're supposed to say to falsely answer.
Exactly.
And therefore it delays them getting help.
Yes.
So that's what I personally have seen a lot of.
Oh, that's such a good point, right? That is the retesting reliability. So what we do is we don't ask people to keep coming back every year. We look at the range of difference and say, unless you feel something is not right, that has changed. You don't come back every year. Yeah, but we have a reason why we ask them to come back. So when it's on borderline kind of results we get, we pay attention to retest, and that's why we need our neuropsychologists to be there, training students. So I talked about students, clinicians. Most of them are graduate students going forward with their doctoral degree, and I think by the time they get to this cognitive test, they are pretty already well trained. So we are very proud of them and comfortable that we are doing the client justice. We talk about older adults who want to help. We really, really need to protect them. Like I said, in ways of safety, in ways of dignity. Very, very important. And I've seen many clients with dementia who do well. All right, so let's not discount people with dementia, because there are so many different domains that they might still have strength in. And families would love knowing, right, that they can work with them on some areas that they're still good. So, well, I've taken this for too long, and I'll have Laurie share more with you.
Before you jump in, Laurie, would you just answer the question that Jen Nimmo has asked, whether Medicare would pay for a neuropsych exam?
Medicare does pay for neuropsych exams. The huge problem is when people don't have traditional Medicare. Medicare Advantage plans, we're finding, well, we're not sure, and we're working actually with AAA right now to identify providers who cover it, who have Medicare Advantage plans. We are not approved for Medicare Advantage, so we can only support those with Medicare. However, when they do come in without Medicare or another plan, then they are able to use our sliding scale fee neuropsych evaluation. And that is a program where all the neuropsych testing is done by the clinicians in training, these PhD in training clinicians, and supervised by a licensed neuropsychologist. That is the program, one of the 3 key programs that we're asking for funding for this year. It's new for our requests because of the numbers of people that are on wait lists for that service. It's tragic that there is nobody else in the community where they can go to get a sliding scale fee anywhere from 3 to 6 hour test, which is what that is.
Yeah. Thank you for asking that question.
And that's specific to neuropsychology. Is that what you're stating, that y'all are seeking funding? Or that was
correct.
Neuropsychology as a criteria of a placement criteria. You're looking for funding for that. It's a unique process.
Correct. It's called under our RFP. It's advanced. It's the advanced screening. Regular screening is the memory screen, the memory clinic. This is a step up from that. So these are clients that have higher needs, need to be assessed. And Magdalena, I just want to share something personal. Just she had mentioned the impact of finding out the results of those neuropsych evaluations. I had personal experience with it this past year. My mom, who lived in Connecticut, had some challenges, and the long distance was becoming very challenging. I'm her sole family caregiver, and she was living independently. And it was clear to me that there were some things that needed to be assessed, and did get her that assessment and found amazing information from that. The domains in her brain that were strong and working and helping her still live in an independent living community in Connecticut versus what our neuropsych team found with the other domains of her brain that were causing severe challenges. But she managed because the other domains were carrying her. It's an absolutely fascinating discovery if you're a family member to see that test result, because it then gave me the tools that I needed to know she can't live in Connecticut anymore because it's cross country. I couldn't be making 4 trips, 5 trips a year. So she's here now. In any event, it's just a story I wanted to convey, because the value in that information is just life-changing.
Thank you, Laurie. And thank you for the question on Medicare. So I just want to add that we actually have a Medicare provider. So that is Dr. Jessica Zamzal. She and myself are the only 2 Medicare providers. Of course, we don't have funds to employ more people. So I take care mostly of the therapy, and she takes care of the testing. And we complement each other's services, because I also under Medicare can take care of clients with all kinds of problems. So to answer the question on Medicare, the first answer is yes. Medicare does pay for it. So in the past, I would have a wait list to see our neuropsychologist under Medicare, another list for students to administer and supervise by a clinical psychologist. And the 2 wait lists is quite the same. So we could plow through, and we never thought about funding for that, okay? But now it has tipped over because Medicare Advantage Plan came in. And so many of them has to go to the wait list. We call neuro team, students are the administrators, but the reports are the same, integrated well, but it takes longer time, right? Because we want to make sure that students are doing that correct too. And we have audio, visual supervision. But all to say, we are so worried now for the fact that the other line is so long. It takes months, and I won't want my loved one to be waiting there. So we're trying to support and to see if we can get more funding, we can reduce that wait time for them. And that's what we're trying to do. Meanwhile, we're trying to check out on Medicare Advantage Plan and see what it entails. It is so complex. So we had wanted to say, let's do it with, do Medicare Advantage with United. It takes us months to even be credentialed because we are partly university system and many other like MPI numbers, and there's so much complexity, will take us almost forever. So that's why we're thinking of, shifting our thinking about how to support. And so we jump from here and there, and hopefully next year, if we do come back and present, we can tell you a little bit more about what we discover and how we can support that population. So why it's so important again is without that neuropsych assessment, yes, it's expensive, but it's a one-time with a wonderful feedback with the family. They get comforted, they get knowledgeable, and they learn to manage. In that, again, it saves a lot of other cost. And I've time and time again have families come back and say that feedback was the best they ever had, because really in the medical setting, you go find which provider is going to sit with you and your family for 1 hour to tell you the details of the strength of your loved ones. You know, what are the areas that they have trouble in and how you can support that. We feel like doing that 1 hour session is going to help them so much, right? And I'll say more next time.
And just to be clear, that 1 hour piece is the tail end of the neuropsych evaluation. So with that, we could go through slide number 2. This is just a kind of an umbrella vision of all the services that we are doing. The group therapy, individual and group therapy that Dr. Lim talked about by our both students and our licensed therapists. Caregiver, family therapy, and support groups. So, you know, there are a few different caregiver programs that we have. There are caregiver classes, support groups, caregiver therapy. We also this year started another wellness group, mindfulness, that was well received, and our student who was facilitating that has moved on. So we're hoping to bring that back next year as well. But those are all group therapy services that fall under the caregiver counseling and training. So as we move along the dial, public information and education, the memory clinic we talked about, the neuropsych and capacity evaluations, the new piece that we're requesting funding for, but we have done for some years now. When we talk about information services, so this year was really an amazing piece of our work. Although COVID was still with us, we actually connected with just under 900 people in the community. And that was during a combined closed and in-person environments. So we did, you know, some education and public information in person, but by far many of it were, they were events that were through webinars and through the internet. And the two biggest ones were just early spring, and those were, and some of you may have attended the Rocky Mountain Geriatric Conference and the Rocky Mountain Conference on Dementia. Those two conferences alone, I think, brought, there were viewers over 500 that attended those conferences. One was in person in Denver, and the other was virtual. So 89% of service units we've provided so far this year, and again connected with 885 persons through the end of March. When we talk about education, we mentioned briefly the Medicare annual wellness visit that was just hugely successful this past year in bringing to the attention to providers, medical providers, that everybody on Medicare is entitled to an annual wellness visit. It's a very specific visit that's often confused with what we used to call, you know, typically you call a wellness visit, which when we're younger, we get it no charge. This is different. This is a wellness visit that is supposed to include that brief cognitive screen, very brief. And the research shows that majority of annual wellness visits are coming and going, and that screen is not being done. and it's a huge disservice. And many don't even know about it. And the research also showed that the majority of people that did know about it, that did utilize it, they were informed about it by their primary care practitioner. They sent them something in the mail. They had flyers in the office. They made phone calls when you know, they were due for their annual wellness visit and told them about it. So slowly the numbers are changing, and that is being taken advantage of, that piece of their annual wellness visit. But it was very gratifying to be able to actually train physicians with that piece that Dr. Lim talked about.
Yeah. I just want to add something that, like Cynthia said, right? Yeah, you work well with APS. We did too. You know, we saw many clients referred by them for capacity evaluation. That is, many of these clients no longer can make decisions. And it was so heartaching to see the family come by. Or the clients coming in for memory clinic didn't follow through with the neuropsych, now report to us under APS, you know, and we say we cannot always be looking at those capacity cases. Something has to happen up front. And that's how we thought about this annual wellness visit that Laurie kind of researched and think that that is also something lacking in the community, because it includes that 10-minute screen. And that's the reason why we're trying to support providers by training them to see what they should look for. Yeah, I just want to add that piece that it makes it so hard to always be working with APS. You know, it's such a hard job, both for them and for the family.
I'm sorry, but we still have some business to take care of yet. I'm wondering if you can.
So we can sum up,
wrap it up, sum it up.
Yes.
That would be thank you.
Sure. So I think that what's important to talk about is, you know, we've, in the spirit of this month, behavioral health month, again, we appreciate telling you about our work and our innovative services. And I think that we would like to advocate for two things here today. And one is the increased visibility of caregivers. And two, the earlier intervention of cognitive problems. And we think that the 3 new services we proposed will in fact propel both of those forward.
Thank you so much for your presentation. Appreciate it. You know, we could spend an entire day with the 3 providers that were here today and learn more about all of your work, but thank you so much for being here today. Okay, we have a little bit of business. Our membership subcommittee, Rosemary brought to our attention that Wendy Farr, some of you know Wendy she was a member for many years, often our membership committee. Rosemary sent her a congratulations letter because she has a new position with the Alzheimer's Association in Utah. And so they will be moving there. So just for those of you who know her, wanted to let you know that. Jen, do you have anything for us from the Strategic Review Subcommittee?
No, not at this time. I'm going to meet with Melissa in between meetings to figure out when our next meeting should happen. We're going to be doing some reviews with the strategic plans. So,
okay, we'll look forward to hearing about that. Jody, our director's report.
Well, the first thing I want to say before I get into my list is what we've heard today, not just recognizing the Mental Health Awareness Month, but ultimately the collaboration that goes on in this community is immense. You would be amazed at some of the events that I attend regionally, nationally, where this level of collaboration just doesn't happen. It's not invited, it's not assumed, and it's not encouraged. And so I just want to say a huge thank you to the providers who presented with us today, those additional providers and community partners that are online with us today. Just what a huge, huge blessing you are as you collaborate with each other, as you collaborate with the Area Agency on Aging, our programs here, our staff. Just what a huge blessing you are to the community. And you need to hear that from me because it sounds obvious. And I think we do well as a staff to thank you for that. But you've got to hear how special it is. Because in the last month, I have heard people say, what? You have competitors working together to serve your community? And it's the most foreign concept. It's the most foreign concept. And so I want you to hear it from me. And I know my staff say that, our providers, I know you all appreciate each other and work together so well, but it is such a foreign concept. I feel like I'm a broken record at this point. It just amazes me. And I am amazed by you. And so thank you very, very much for all you do for our community. So I'm going to dive into an enormous list of updates because it's been that kind of month and a half or so since the last month since we met. And there's just so much good going on. So bear with me as I work through this. Feel free to ask questions at the end or catch me after the meeting. I do have a brief meeting. A couple of staff members and I will be meeting with Silver Key. So stick around if you need to grab me. I'm happy to discuss this. But along those same lines, this collaborative effort, a big part, I do want to encourage those of you who are in the building, in the room today, make sure you log in on the sign-in sheet. In-kind time and mileage is huge. We talk about it, we share about it. It's huge for us because it's a way that we can access the funding that we have. So we have the funding, but there are occasions where we cannot access that and get that out, those services out into the community. So when we are asking you to track your time during the month, especially those of you as board members and in your subcommittee work, when we're asking you to track your time, there's a big reason for that. It's not for yet, it's not for a slideshow. It's because ultimately that allows us to access more of our funding. So thank you very much. A huge thank you to the TRS for the time that they put in. Chris summed it up well, where this is probably one of the most challenging TRS processes we've gone through in the last few years because the needs are great, and we know that. The needs were great and exemplified through the reports and requests from our providers, and this was an exceptionally challenging time. I am happy to let you know that there are still at the national level discussions around increased funding. However, as Chris did reiterate at the beginning of the meeting today, we have been told from the state to expect flat funding this year and probably into the next couple of years. That's unfortunate from the base standpoint, but as we continue to receive emergency funding, what is still being considered emergency funding, we will continue to distribute that very similarly how we have. Right now, there are two packages. Most of the providers have heard this because we have started some quarterly meetings to let the providers get introduced to one another, receive presentations from other providers outside of our network, educational opportunities. We'll also use those quarterly meetings as opportunities for training and things like that. But wanted to let you know, there is a package of funding that has been received. It's just simply called the Arpa Funding. It's the American Rescue Plan Act. Right now, we're sitting on that because we need to invest additional time in planning. The intent of this funding package is not for programs and services. It is intended for infrastructure and capital growth, looking out to the 5 to 10 year time frame. And so we have not begun distributing that yet because we need more time to look at what this what potential could be for that infrastructure growth across the 3-county region, whether that's several projects or a single or 2 larger projects. We just don't know the answer to that yet. However, we will have through September 30th of 2024 for allocation and through about that same time frame of 2026 for spend down. And so we do have time, whereas previously with some of the CARES Act funding, it was receive, spend, 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 and spend fast. So we've been doing that pretty well along with the carryover funds have been able to distribute almost all of that out into the community. We still have a few dollars in carryover, but not much. And we still have some CARES Act that we're going to be asking our providers to draw back that they haven't spent, so that we can get that spent down by this fall. So providers who are with us in the room and in Zoom, you'll be hearing from me. So if you're sitting on CARES Act, I'll be giving you a ring so we can figure out if you still have plans for that. That's fair. I just need to have that conversation with you so we know where that sits. In March, I did some traveling, was able to go to the U.S. Aging legislative and policy briefing in Washington, D.C. I got to meet with several administration and community living staff members. Again, talking more about the match, not just match with the AAA, but match for our providers. Right now, some of the most difficult part of the spending process is the match that's required. So if we can find some either temporary forgiveness or a change in how that's approached, then we can truly spend more in the community and spend and serve more seniors in our region. So I will continue to share. I take every advantage of those opportunities to shake hands. They put their pants on the same way I do every morning. So I figure I'm going to shake your hand when I got the chance. So we'll just continue doing that. In that same week, while I was in DC, I got to meet with Senator Hickenlooper's office to talk about some of the needs. I approach all of these conversations from a regional, state, and then the national level. I always put priority on Region 4. So we talk about that, what the services look like, where the challenges are, where we could do more if we had more. Many of you may be familiar with the now defunct Build Back Better funding, as the BBB funding that went nowhere over a very labored process at the national level. However, there is a new funding package that's being put through the system right now with Senator Casey out of Pennsylvania, who's very, very strongly passionate around senior services. So more to know about that, or more to come on that as we watch that process. But then also just to share with you the President Biden's very recent end of March budget update, a budget recommendation, had very strong recommendations around senior services, particularly within the Ombudsman program and family caregiver supports. And so more to come on that as that's being hashed out. And along those same lines, I have a call this afternoon with Senator Bennett's office to talk more about services. So I've begun a political thing, I'm not even sure, a political trail that I never knew or thought would be possible. But these are the folks who have access to making things happen at the national level. And so I will continue to be making those efforts when I'm afforded the opportunity. And in fact, on Tuesday, I was called up to the state capitol to talk about the senior homestead exemption. There were 2 updates, and so it was brought back as a continuing resolution to come to the voters in the fall. However, it did fail. I'm very, very disappointed in that, but talk about seeing how the sausage is made. Boy, that's an interesting afternoon, I'm here to tell you. the two changes that were made were portability for our older adults, as well as an increase in the base funding amount. So, so that will, it did die for all intents and purposes. It's not going forward this fall, but it will come up again in the spring at the next legislative session. And I did get to work with Senator Liston's office and Senator Janal on this process, and will continue to be part of their work group on that. Let's see. Some of you have already seen the new yellow books. I do want to throw out, we do not have very many yellow books here because we gave them out to the community. And so as everything that we've seen around services and materials, cost of paper and printing is incredibly higher than the last time we printed yellow books. So I'm going to read very quickly through this list. If you need some for your organization, a case or two, whatever the case might be, please contact Lucy here in our office. She will make the appropriate arrangements to get you some, whether it's from us or from one of our other distributors. So Colorado Springs Senior Center, Colorado Springs Housing Authority, Department of Human Services, and that's specifically at the Garden of the Gods offices, Discover Goodwill, Evans Army Hospital, Memorial Hospital, Peterson Retiree Office, Peak Vista, Pikes Peak Hospice, the Lindstrom VA Clinic, Pikes Peak Library District, and Silver Key Senior Services. They received a direct shipment of yellow books. And so I'm going to send people, I would encourage you to send people to those locations as we begin our outward facing communication. That list will be made available as well. But if you do need some for your organization, feel free to reach Lucy here in our office. I'm going to highlight a couple quick things. The U.S. Aging Annual Conference will be in Austin, Texas this year. I am a board member. I don't know if I've mentioned that before, so that's why I'm suddenly doing all things U.S. Aging. But I am Melody and I will be attending that in July this year. The board meeting sandwiches that conference this year. If you're interested in attending, because Austin apparently has really great barbecue as well, make it a twofer. If you're interested, let me know. I will get you the information, because it's not just for those in aging business. It's for all. It's a large hundreds and several thousand people attending all things aging. So that is open to the public. So if you're interested, please let me know. Jen, the discussion around the next 4-year plan is already starting with the state. And so that's actually going to be a conversation we'll start to hear more actually on Monday at our state APAC meeting. And so I'm going to be in touch with you, and Melissa and Melody will be part of that conversation, and we'll talk about expectations and timeline and that kind of thing. And so this is another one of those hang on to your hats, because it's a very intense process, but mandatory and required. And so I love that Jen and her subcommittee will be part of that process. Another source of funding, which we don't have a whole lot of details on, and so I'm not going to share a whole lot of details, is a stream of funding that will help support CNA scholarships. So that's all I have to share on that. More to come. And then, as you well know, I will continue to push for more funding into our region. The need is great. The need is evident. The service providers are here to make those needs met. We just need more funding. So that continues to be my message as we reach out to the community. If there's anything that I touched on, you have questions, please feel free to track me down. And thank you very much, Madam Chair.
Thank you, Jody. Lots going on here. Okay. Oh, are there any questions for Jody?
What is CNA?
Certified Nurses Assistant.
That's
yeah.
It was.
Any other questions?
Is Lucy out in the front of the building to get yellow books?
She's here in the office.
Okay.
She's our information assistant.
Awesome.
Lucy's our information and assistance director and takes care of the yellow book distribution. So she's not here in the office today, but if you want to grab one of her business cards off the wall, you'll be able to get in touch with her.
Thank you.
You're welcome.
Any other questions for Jody? Okay. In terms of my report, I'm going to keep it short because we've had so many interesting presentations today. But I just wanted to thank again the TRS members that reviewed all those proposals. You know me, I like to look at numbers a little bit, and we had 17 proposals. I mean, if you spend a half hour on each, you'd be spending 8.5 hours. If you spend an hour on each, you're spending 17 hours, plus the lengthy meeting that we sat through. I don't want to scare away new members by giving you those numbers, but I just want to bring to the attention of all the RAC, the amount of time that people put into this and how serious they take. Oh, and I forgot we did a transportation proposal before that. So as I look at Lori there, so I just want to say thank you to all the members. You know, this sort of goes in waves, you know, in terms of which committees are most active at any point in time. But right now in the spring, it's always our TRS committee. So thank you again for the amount of time you put in. And then I just wanted to bring something to your attention. Jody has put me on the national organization, and something came through the other day related to one of the members of the National Aging Association put together this flyer on home repair and modification resources. And basically they developed it in such a way that a local person or the AAA here could actually take the developed flyer, put in their own information, and you'd have, you know, very good information, and then you just put your own information in it. And it seemed to me like a wonderful idea, so that a local organization wouldn't have to develop all this on their own. They just put their name in and phone number and how you contact your, and you have a lot of good information on home repair and modification resources in the area. Anyway, I saw it as, oh, that's a great idea. Save our local organizations a lot of time, and yet you get solid information out. So that's all I have today. Are there any discussion items, Chris?
I'll try to make this as brief as I can. B sort of stated it. I would not discourage anybody from getting involved in the TRS. When it all comes down to it, it's still about this. And understanding the process, especially since you have this devoted nonprofit and even for-profit businesses that are seeking helping seniors, and it's such a prevalent problem and all the nuances within it. I cannot say how much I've enjoyed this. I've been doing it for 4 years and I wouldn't trade it for the world. It's very educational, it's very informative, and it opens up pathways just informationally for me to do my own investigations. So that said, this year, and it's really the same every year, but this year, the numbers that were brought to us were, there was a lot of work. Everybody that puts together their RFP, you know, if you've written a grant, if you're putting together your numbers, the process is tremendous. The staff here takes all of y'all's information and assimilates it and puts it together for us. And it is pretty impressive what they do. I'm really, really always amazed by that and grateful that they take the time. I personally actually calculated my hours this month. I put in 57 hours to process this information. And think about all the volunteers and all the staff that do more than that. So my point is appreciation for the staff here and what you've done. Everybody, Tris, Laura, Melody, Melissa, Jody, Casey, and those that I don't know. I'm very, very moved often by your dedication. So thank you. And providers, thank you for what you do. Jolene, if you're still there, we've always spoken of your passion and how much people at Fountain Valley appreciate you. So thank you for your service also. So thank you, everybody.
Thank you, Chris. Any other discussion items? I'm just going to bring one thought to your attention, and then we can talk about it at another meeting when we don't have so many things on the agenda. 2 years ago and before that, we used to go out and visit some of our remote sites with our meetings. We used to go up into the mountains. We went out to Fountain Valley, etc. So if anybody has any thoughts on when and if we can begin that again, I found it just fit for myself. I had never lived in a mountain community before or near mountain communities. And it was so informative just to drive up to Park County or to drive up to Teller County and say, oh, now I understand what our representatives are telling us, you know, about delivering services. So anybody have any thoughts? Yes.
I work in Teller County on Tuesdays, and I do travel up to Park County every once in a while too. But I was telling the Aspen Mine Center up in Cripple Creek about the Regional Advisory Committee, and they have a conference room, and they are also gaining another building. And so I think they would really probably be interested in potentially hosting a meeting up there. So I can talk to them about that. Ted Borden is the director of the Aspen Mine Center. And so, yeah, I can touch base with them. I'm going to be up there tomorrow, actually, so I can see if they want to do that.
Yes, we've done one before COVID. Yes, before COVID period time.
And I'd like to put in a plug for our Eastern El Paso County area. That is so wide open, and the plains are sweet. We notice our mountain family to the west, but the plains are enormous in terms of their needs and the isolation as well. So I would like for us to continue thinking about them and how we can better serve them in a connected way. I am just thrilled at all of the connections that I see happening that are so positive in this larger community. And so I just want to say thank you as well.
Thank you. Well, we'll explore that more. I'm hoping that when we feel safe enough, you know, that we can do that again. Because like I say, I really feel like we learn a lot going on site. Okay, our next meeting is May 26th. And for our board members, our executive committee meeting is always the first Wednesday at 1, and that's on Zoom. Without any further ado then, I will adjourn our meeting. Thank you again for your attendance. Look forward to seeing you next month. Bye now.
Thanks. Have a great day.
Bye, everybody.